Welcome to Own Your Heart Health. I'm Dr. Regina Druz, your holistic cardiologist. This week, we will dive into common heart health concerns, uncovering root causes, and unpacking scientific discoveries and controversies. The information provided does not constitute medical advice. Please contact your healthcare practitioner before making any changes that may impact your health. Welcome, everybody. This is another Happy Friday, and I am absolutely thrilled to be together today with a great friend, a mentor, a colleague, Dr. Vivian Asamoah. Dr. Asamoah is an integrative gastroenterologist. So I'm an integrative cardiologist, and this is an integrative gastroenterologist, and Dr. Asamoah is changing people's lives every single day, not just where she's practicing, which is in the town of Katy or Houston, Texas, in the neighborhood of Katy, but actually nationally and internationally. She is a renowned speaker. She is a faculty for the Institute for Functional Medicine, runs a phenomenal signature program that addresses people's digestive issues from the integrative perspective. So welcome, Dr. Vivian, to the show.
Thank you so much for having me on, Dr. Druz. This is great.
Excellent. So I'll ask you the same question I ask all of my guests. How did you grow up to be an integrative cardiologist?
Well, I'm not a cardiologist. You're a cardiologist.
I'm sorry, an integrative gastroenterologist.
I know you want everybody to be a cardiologist, but...
That's what happens when you're having too much fun. But okay, integrative gastroenterologist.
I guess it began with medicine, right? And so when I was in med school, I would say actually when I was in internal medicine residency in Baltimore, I trained at Hopkins. It was actually my mentors. And so I think sometimes your mentors see something in you that you may not see in yourself. And one of my hepatology mentors says, V, I think you would be a great gastroenterologist one day. And I said, really? And he said, absolutely. You love procedures. You love internal medicine. You love digging deeper. And they offered me a fellowship in gastroenterology at Hopkins. And it was a great match because I absolutely love gastroenterology. But when it comes to integrative, I was always very interested in nutrition. So at Hopkins, I actually taught the second and third year medical students. There are very few modules on nutrition. As you know, Regina, we need a lot more nutrition in our medical schools. But I was their lecturer for nutrition, 2 modules. In second and third year. And that led me on to, with gastroenterology, it kind of paired very nicely. I was very interested in working with the dietitians. They say, pick an elective. And I say, I'm going to work with the dietitian team. Pick an elective. I'm going to work with the obesity team. So I was
and people are like, what? She doesn't want to run and do your CPs?
CP, you don't want to do EUS. And I'm like, I'm going to work with the bariatrics and the nutrition team. And I saw the impact of nutrition on our patients in terms of just kind of looking at chronic disease from the obesity perspective and working with the bariatric surgeons. And I said, this must translate. I think it starts in gastroenterology and then it has to go all the way to surgery. That's how we end up there, is because there's been this chronic disease that's led to now, other complications requiring a more aggressive approach. So when I started practice, I incorporated dietitians right away on day one. And that was very, very helpful in terms of educating my patients and helping in terms of behavioral change. But then I discovered integrative and functional medicine.
So how did that happen? You see, that's always, what's the inflection point?
So I know, a lot of people say something happened personally in my life and I got sick, my family member got sick. But for me, it was my patients. It was really the day-to-day noticing that continued prescription is not a sustainable solution. And a lot of my patients are coming back to me still dissatisfied, upset, just like, well, what's the long term? Do you really expect me to take this medication forever, Dr. V? Like forever? And so I had to start thinking about, well, how do I reverse? How do I move from just prescribing to really healing and transforming, right? Reversing disease. And that's what intrigued me about functional medicine. One of my mentors at the time was Jerry Mullen, and he lectured for the GI
He's
model.
also another Hopkins guy, right?
Yeah. So of course, my mentor from Hopkins. And so, I started reading his books and reading books from other gastroenterologists like Robin Chutkan. So you only know who you know, right? It was our little gastroenterology
Right.
world. And I was like,
Yeah.
well, who else is doing things a little bit differently that may be able to provide me with better answers for my patients? So for me, it was just what I was doing in practice just didn't seem to be making sense. And when I dove into the world of functional medicine, which was more of a root cause, reverse, transform, heal, sustainable, I said, I think this is the right place for me. I think this is what I'm looking for. And implementing some of the very, very basic foundational strategies, I saw immediate results in my patients. So
That's amazing. Amazing. And, and this is sort of like a recurrent statement that, I have a lot of doctors on the show, a lot of my colleagues, and also, we all seem to travel in a similar fashion. What pushed me toward integrative cardiology were also my patients, because prior to that, I thought that I was a pretty darn good cardiologist, but just not getting the results that people really wanted, and beginning to see that some patients literally they took their health into their own hands, right? Trying to improve it. And so that process starts, and it's fascinating. So I'm sure that you're on top of these two huge areas that are not just shaping integrative gastroenterology, but sort of shaping the field of gastroenterology, spilling into cardiology, reverberating through fields of longevity, if there is even a field for longevity. I'm not so sure about that. But the point is that there are these two huge areas where I think you as an integrative gastroenterologist can give us a lot of interesting knowledge and sort of tidbits and expert insight. And one area is microbiome, and another area is so-called metabolically associated steatohepatosis or steato liver disease. I'm sure I'm not even pronouncing this right, but
with inflammation.
Inflammation, exactly. The abbreviation is MASLD, so I'm sure you're going to talk about that. But let's go into the microbiome. So first of all, just to make sure that we have a level playing field, because it is possible that people listening to us may or may not have thought to themselves, what actually is a microbiome? What is dysbiosis? Why are we even discussing it? So can you give us just some baseline definitions of what microbiome is, what dysbiosis is, and why we are actually looking into it?
Absolutely. So, I think when we hear a lot of our patients, and I like to talk really just in the layman's terms that patients hear, because I think, or refer to, because I think that's how they make the connections. But I think when a patient comes to me and says, what is my gut health? How healthy is my gut? I think what they're referring to is, what is my microbiome status? How healthy is my microbiome? Do I have the right type of bacteria? Am I nourishing my body with the right nutrients that feed this microbiome? And they've realized the importance of it because, of course, the Human Genome Project, the microbiome projects that have been going on for the last decade across the globe are telling us how important, and perhaps this microbiome that we have in our system may be even more important than the human cell. And it is composed of about, trillions of bacteria, virus, fungi, even parasites, archaea. These are organisms that coexist with us almost immediately right after birth, right? They start developing after birth when there is exposure from that vaginal lumen outwards, and then exposure to the world and exposure to nutrients and everything else around us. And they start colonizing our gut, predominantly our gut. That's where most of the microbiome is found, is in the large colon.
So the large intestine, right? The area in the large intestine where most of them live.
Areas where you find this accumulation of organisms, right? We have some on our skin, we have some on our mouth, we have some even in our nose, our ears, our vaginal, any cavity that is kind of moist and warm, but the majority is found in the colon, right? And we know that over the years, we are learning and continue to learn that they play a very important role in how the machinery of the body works from every angle, whether it's from helping us digest and extract nutrient from food, metabolizing these nutrients to active metabolites we can use in the body for whatever cause, whether it's balancing out the immune system, whether it's converting some of these metabolites to neurotransmitters like serotonin, dopamine. It is actually, they are involved in actually metabolizing medications that your physician may give you into supplements into their most active components, so they may work in your system. So they do so much in our body, and without this microbiome, we really don't exist.
What is then dysbiosis? And is dysbiosis the same for every person, or is the definition of dysbiosis varies from individual to individual?
So dysbiosis, I would say, is an imbalance in the microbiome, right? Dysbiosis means something is altered. There's some kind of dysregulation, right? So we know that we have certain families of these different bacteria, archaea, parasites, whatever, that exist in our system. And when there's an imbalance, and it's a great question, because you have to say, well, what are we comparing this imbalance to? What is our gold standard? Who is our gold standard of having this perfect gut microbiome? I think it's still a question.
Tell us, who is the gold standard?
It's still a question that I think microbiologists are not able to answer 100%. But what we do know is that we need a balance of healthy bacteria, and we have to make sure we have enough, and we have to make sure that we don't have too much. Because the issue is, when things go out of balance, the complex interaction between these different families and strains and genre is off. And that therefore affects all the functions they have. So that balance is important. And that balance is primarily determined by what we eat, what we consume.
Hi, everyone. It's Dr. Regina here. I know there are contradictory opinions about nutrition for heart health and longevity. Discussion often gets heated and confusing. There are those who push for low fat, low cholesterol. Then there are fans of a ketogenic diet. There are many anti-meat voices as well, suggesting vegan or vegetarian style of eating. With all the chatter out there on what and how to eat, my team and I decided to create a tool for patients, medical professionals to clear the clutter. It is called Holistic Heart University, and it provides on-demand courses, nutrition and lifestyle resources, information on supplements to make it easier to understand how to make healthy choices for your heart. I'm especially proud of our open office hours for program patients and the Q&A feature where you get to ask your individual questions and put us in the hot seat. Head out to the show notes for the link and use my special promo code to get a huge 20% off on our annual health and wellness subscription. The code is OWNER20, and I'll see you in the office hours. So what would you say, obviously this is such a complex and complicated area, right? Because figuring out what the microbiome composition is this microbiome composition aligned with the individual where we're sampling it from, or maybe it needs to be manipulated, and in what direction to manipulate it and how? This is a very complex. And, what would you say are top 3 conditions where, after these decades of research that is still ongoing, on all levels, what are the maybe top 3 conditions that, as an integrative gastroenterologist, you could say this is definitely a situation where microbiome plays a huge role?
Are you referring to clinical, like sort of chronic conditions?
Chronic conditions, or any, typically there is some concern, of course, that microbiome not only affects gastrointestinal conditions, for example, irritable bowel or inflammatory bowel disease or colon cancer, but it has more of those systemic effects, right? Really predisposing some people to be insulin resistant, or potentially influencing people's ability to regulate blood pressure, or even related to things like dementia or depression, right? So
I think that in that sense, the top 3, I would say, chronic conditions or diseases that we're seeing, where I feel we definitely have a lot of information that the microbiome is definitely impacting or resulting in chronic disease. I would say number one, the biggest impact I'm seeing right now, and I wouldn't have said this 5 years ago, but I would say it's everything related to the brain. So Alzheimer's, dementia,
Alzheimer's,
and even psychiatric diseases. Absolutely. I think we are seeing, even in the evolving diseases like autism and ADHD, I think we are seeing some strong evidence there that there's definitely a connection in terms of the types of the bacteria, the strains that you're seeing in some of these conditions versus others. In your field as well, in cardiology, I think we're definitely seeing some clear evidence there and certain strains that are associated with certain types of diseases based on metabolites that are being released.
Right.
As you know. And in gastroenterology, I think the biggest impact we're seeing is when it comes to functional GI diseases like irritable bowel syndrome, functional dyspepsia, chronic constipation, everything that's related to gut-brain axis issues, we're clearly seeing clear patterns. That's what we're talking about, right? Here we don't talk about like, oh, it's just this bacterial strain or it's just this, we're seeing patterns that clearly suggest that every time we see this kind of pattern, this is the kind of pathology that we're seeing. But I feel like it also it spills over, right? In functional medicine, we just don't talk about just dementia or just cardiovascular or just GI. It definitely spills over in terms of all of these become interconnected at some point, right? So
of course.
If you see this microbiome pattern, I don't think you can isolatedly say, oh, definitely high risk of coronary artery disease. This is going to be a much higher risk of hypertension. You can say, I'm seeing a profile that is going to increase TMAO and it's going to increase potential hypertension or coronary artery disease. But that same profile can also increase your risk of metabolic liver disease, right? But they're all interconnected and potentially increase your risk of cardiovascular. I'm talking about cerebrovascular disease.
Of course.
It's the same pattern, right? So which will also lead to maybe potentially vascular dementia, higher risk of strokes and whatnot. So just the way we look at things from an integrative and functional standpoint, that's the microbiome. It
so
affects
what makes, Vivian, what is sort of connection between microbiome and, let's say, Alzheimer's type dementia? Do we know, what specific entities are being made or not being made by microbiome that potentially may contribute to it? I recently spoke to a colleague and she specializes in oral microbiome testing and also sleep apnea. And, on some of those oral microbiome tests, there is a specific bacteria, which name, of course, is too complex for me to recall right now. But it's interesting because in studies, this specific bacteria was traced to making toxins that actually penetrate blood-brain barrier, causing neuroinflammation and potentially contributing to Alzheimer's dementia. So is it the same path or is it a different path? Kind of like what gives when it comes to the relationship between microbiome and, brain health?
I'm sure that I'm not an expert in Alzheimer's and dementia at all, but I'm sure there are definitely specific strains that we're seeing that influence inflammation and perhaps even deposits of certain particles in the brain that will enhance and increase the possibility of dementia. It's not an area of expertise of mine, but I have a feeling that I'm very sure that it's very similar to the same patterns we're seeing in cardiovascular disease.
And so when you do, I'm assuming that, as an integrative gastroenterologist, you do a significant amount of stool testing, right, to actually assess what people's microbiomes are. So can you explain what the stool testing is and what would be sort of the gold standard of stool testing if one does even exist, and what one can expect, from getting a stool test? What kind of information potentially may come to light that could help a person to take some of those early steps or precautionary steps to really realign their microbiome in a way that will allow them to protect themselves, certainly not 100%, but with something that they can certainly do.
So when it comes to comprehensive stool testing, there are many there are different types, right? There are different types of stool tests, and different companies are doing different things. You have some companies that are strictly looking at PCR, right, testing, which is not complete microbiome testing. When we talk about having a bird's eye view and really doing a drone view of what your entire microbiome looks like, then you want to do whole genome sequencing, right?
So genome sequencing, so PCR, by the way, stands for polymerase chain reaction, in case people don't know. I'm just going to mention that. And that's sort of just amplification of, things which are found. But the genome sequencing, right? The genome is that it's actually sequencing of the genes, right? In essentially what the bacterial genes. That's the way I understand it. Or am I not correct on that?
Bacterial, parasite, viruses, as much as it can. You can do whole genome sequencing as much, but it's sequencing everything that is available to see. Wow. When you're doing PCR, you're just doing 16S. You're strategically looking at perhaps 30 or 35 special sequences in certain bacterial strains. So you're not capturing everything, right?
I see.
And so when you're looking for microbiome assessment, you definitely want to do whole genome sequencing, next generation sequencing, to get an array of everything. And it's very good at looking for bacteria, but right now we don't necessarily, we're not necessarily able to see all the strains of yeast, for example, right? We're not necessarily able to.
But we see most of the bacteria, we do see.
We absolutely see most of the bacteria, right? And so when we're looking at, we have a good quality test that's doing next generation whole genome sequencing, and you're assessing, you want to start by first looking at something called the Shannon Index. I'm not sure what type of testing you're doing, but with the Shannon Index, you're really comparing it to what does a healthy microbiome looks like. You're comparing it to some kind of gold standard.
But is this, so let me ask you, because I had seen it in the reports and I always feel like it gives me a little bit of a confusion. Who defines what the healthy microbiome is? Is there some sort of a biobank or a definition that like, okay, these strains and these amounts are healthy? Like, how do we know?
It has been defined by them looking at microbiome, like doing assessments in not only just sort of globally per age, where people are. That's kind of what they're looking for. They're looking at those main families and how much of those, we know what major the groups are, right? And so they're looking at how much do we have in each category and what is the diversity like, right? We know there's going to be some influence based on where you live. It can even be affected by ancestral, your ancestors and what their microbiome was, right? It's affected by what you're eating, what your exposures are. So that's where you have to take those things into a grain of salt, because someone who's vegetarian is going to have a slightly different microbiome to someone who's eating more of a carnivore diet. And those have to be taken into account when they define what that healthy standard is. Right. That has to be.
Is there any, because this comes up often, and there's all these very heated debates between people who are vegan and vegetarian, and I guess people who are just Mediterranean like me, but the point is that do we know, based on the current research or research that accrued over time, is a specific diet best for the microbiome, or there is no such thing?
So I think what I've learned and what I continue to experience over the years is that two things. Cultures will adapt to what they've eaten over the years and optimize their microbiome based on that, right? So if you come from a culture where ancestrally, for whatever reason, you've eaten just pure vegetarian foods, your microbiome will adjust and adapt to fit to that, right? We even know over the years, back, centuries and centuries and centuries ago, we didn't necessarily cook food, right? So if you look at the microbiome of people who ingest mostly raw foods versus cooked food, completely different. And so you start developing different strains that consume food or use food differently and adapt to your body, right? And so that certainly plays a role as well. There's some adaptation and optimization based on what you've been eating over the years. That's one thing. The second thing is that diversity we know is important. Mm-hmm. Diversity in terms of whatever you're eating is extremely important to be able to have all the groups, the Actinobacter, the Bacteroidetes, the Firmicutes, to be able to have a good amount of all of those families that do the job they need to do, because it's all about, it's a question of interaction, it's a question of ratios, it's a question of balance, right? Which is why moderation is key and diversity is very important.
So it's interesting because, the now and then studies come out and say, oh, in such and such population, let's say in Asia or in Africa, the microbiome is, so much more different than from people that live in some other part of the world, let's say like United States or Europe. And I always find that these studies sort of are set up to detect the difference, of course, because we feed, we eat and the bugs are being fed by our food. And the ones that like our food, they grow, and the ones that don't like our food, they don't grow. But there are some interesting things that I saw. There is an interplay, of course, between the food and the bugs. And just yesterday, and I shared with you a few minutes ago, American Heart Association came out with a document, and maybe I will bring it up because it just goes to show you how complex it actually is. And so let me see if I could share it with our listeners. And if you're listening here, you may want to jump quickly onto the video for this one, because this is where I'm trying actually to see whether or not, and somehow it didn't open yet, but we'll try again. Trying to show you what basically American Heart Association put out there. And they put out, and let me bring it in here into the view. It's called AHA Science Advisory. And this is what, American Heart Association is very good about putting out science advisories. They're important because they kind of tell us, well, that's sort of like the state of research, right? And so it is a hypertension and gut microbiome advisory. So it's not guidelines. It's sort of a summation of research and understanding where the research leads us. And something here that I didn't actually know about is that, and this is very interesting, and they put us this nice infographic here, is that they're highlighting salt, and turns out that salt actually interferes with lactobacillus. And that's the relationship between salt and hypertension potentially could be something that has to do with lactobacillus. And then they go into a bunch of other foods, and they present fiber that I actually never heard of. So I'm curious if you are maybe familiar with this type of fiber. Maybe it has a simpler name, but it's called HMSAB, which is actually an abbreviation, and it's a type of a starch which is enriched with acetate and butyrate. I was curious if you know what it is.
Starch? Is it a resistant starch?
Resistant starch is enriched with, acetate and butyrate, which, of course, what bugs are producing pretty much on the inside. So I'm wondering, what actually is it? Does it have a more, colloquial name other than, hem?
Well, I mean, the resistant starches are generally what we recommend. When we recommend to patients to consume like green plantains or rice and potato starch, we know that they definitely increase our short chain fatty acids. These are the types of starches that the bacteria feed on to make those short chain fatty acids. So you get the most microbiome modulation with these type of starches. Right?
Interesting. And so, but is there some sort of a medical food that actually enriches those starches with acetate and butyrate, or is there no such thing? Because I'm curious.
I mean, there are medical foods, like you can actually buy medical like these powders that are purely just resistant starch.
Interesting. Because this one starts, so I found what the abbreviation stands for. It stands for high amylose maize-resistant starch modified with acetate and butyrate. So HEM-SAB. And, and it's interesting, those HEM-SAB trials, they reduced, blood pressure across the board. And it's not a small reduction because systolic blood pressure dropped by an average of 6 millimeters of mercury, which is, doesn't sound like too huge, but, but every sort of millimeter matters.
Absolutely. Absolutely. No, I'm sure you can absolutely purchase these. This is what they use in research studies, right? To make sure they're getting that pure resistant starches. So you can get it through food as much as possible. If you know that the types of categories, as I said, rice and potatoes and green plantains and high maize resistant starches, but this can be definitely purchased if you look it up. Yeah.
Do you have a specific sort of ballpark rule of thumb number that you shoot for in recommending to patients with regard to resistant starches? How much of that to consume with regard to fiber in general? How much of it to consume? Like what sort of a rule of thumb that people?
No, I have never been specific about resistant starches. Maybe that's something I should look into. But we generally we generally speak more in terms of fiber, because at the end of the day, we're trying to go back to nutrition, right? Nobody's going to be, I don't want to supplement anybody with a resistant starch every day if they're not eating natural fibers. And the benefit of the natural fibers is not just the fiber itself, but a lot of these are in high polyphenol rich foods that we also want them to consume for the antioxidant effects. And in women, for fiber, we say definitely about 25 grams, sometimes up to 30. In men, 35 and up is ideal. So we start with that as a criteria, but I have not advised the patient to eat this percentage of resistant starches. The way I have used resistant starches in practice, and there's a brand that I actually get from Canada, I forget the name and I'll share it with you, is if I'm trying to aggressively modulate that microbiome based on the patient's history of chronic illness, right? Maybe I'm dealing, and we're going to jump into the topic of metabolic associated liver disease. I will, in the beginning, if I notice significant dysbiosis, I'm noticing there's definitely an imbalance in that bacteroidetes and firmicutes ratio, and I'm trying to increase that, or I'm noticing that butyrate levels and propionate levels and acetate levels are very low, and I'm really trying to push that up. I will, in addition to asking them to eat more fibers and get to their goal, add a resistant starch supplement like 1 serving per day for 3 or 6 months and see if we can shift the microbiome.
Interesting. So that's definitely important because, some of these components that bugs are producing, like butyrate, for example, I also didn't know that butyrate is capable of lowering blood pressure. That was a discovery for me from this article. I thought that, butyrate's major role was to protect intestinal mucosa and, of course, assist in, hormonal clearance. But I did not know that, it actually has a pro-hypertensive effect, which is very interesting. So I think you mentioned this already, so we're going to switch gears. There has sort of been an explosion, right? Or maybe newfound understanding that there is a specific type of liver disease that is metabolically associated. So tell us about it. What is it called? And, what are we actually seeing, and why we're seeing it?
I love the fact that you asked me to speak on this topic, because I think it really aligns what I do as a gastroenterologist and hepatologist with the microbiome. I think this is where we see the most evidence as to how the microbiome can shift and affect inflammation in the liver, and why we're seeing, this increased, really explosion of fatty liver in the world today, not just in the United States. We're seeing about 1 in 4 patients has fatty liver, right? 25%. And this is globally. And we know that this is translating to much more than just fatty liver. The reason why, and the term was changed several years ago, I think it's now becoming popular. I think it was changed maybe about 4 or 5 years ago. We used to call it just fatty liver, or non-alcoholic fatty liver, or non-alcoholic steatohepatitis when there was inflammation. And the entire focus was based on alcohol. And that was deceptive in some ways, because we omitted to understand what was the root cause. Why, right?
Right.
Back in the day, we used to even call it cryptogenic. Like, oh, we don't really know. It's like a secret.
I remember that. I remember being a resident when it was still called cryptogenic. Yeah.
And so I think redefining that and giving that accurate nomenclature also lets the patient understand the root cause. It's a metabolic dysfunction. So now we call it MASLD or MAFLD or whatever, metabolic dysfunction associated steatotic liver disease, right? So that metabolic dysfunction is very important, because then that tells us that this is associated with this metabolic syndrome. For which you as a cardiologist, you know very well the criteria for, right? High blood pressure, dyslipidemia, that high triglyceride, the insulin, all waist circumference. Now we have better markers to even determine that all of this is affecting this insulin and fat metabolism, which is then leading to this chronic liver disease. And I tell patients now that, this fatty liver is not a liver problem. Let's just put that.
Yep. It's a metabolism problem.
It's a metabolism problem. It's actually, before you come to me, your primary care doctor or your cardiologist, endocrinologist must be involved in trying to reverse this dysregulation. And the dysregulation truly is a gut-liver axis issue, right? We hear a lot about brain and gut health, right? Brain and gut. We hear about hormone and gut. But there's a very close connection, and probably one of the most important connections is between the gut and the liver. There's so many interactions between this portal vein that they share. There's a lot of communication between the two, and we can dive into that a little bit. But when there's dysbiosis, right, that in turn is going to affect the liver, because when there's dysbiosis, an imbalance in the gut microbiota, there you're going to develop what we call intestinal hyperpermeability. You're going to have
leaky gut,
in
plain English.
Exactly. You're going to then have metabolites, or what we call microbial antigen proteins, filtering out of that intestine into the bloodstream. And the direct connection going into the bloodstream, it's going to go through that portal venous system right into the liver. And once those microbial products, it could be LPS, it could be metabolites of other toxins that are formed as a release because as a result of this dysbiosis, once they hit the liver, they then affect a cascade of inflammation and trigger stress and oxidation in the liver. And that in itself affects the hepatic synthesis, or creates that lipid dysregulation, feeds the fatty liver, and then contributes to what we call steatohepatitis.
It's very, very interesting, because what I find, and you're right, as an integrative cardiologist, I see the spectrum of this as well, right? And we talk about something called dyslipidemic triad, right? And liver is very central to that dyslipidemic triad, where basically if a person is insulin resistant, even early insulin resistance, not the one where, hemoglobin A1C goes up, but the tissue level insulin resistance, muscle, liver, fat. If that insulin resistant is present, and there are free fatty acids floating around, this is where liver starts to pick up some of these components, package those up into various ApoB particles, and send those out, right? And so we commonly see this, right? We see high triglycerides, we see high or, mildly elevated ApoB or LDL cholesterol, depending on what people are measuring, and we see low HDL. And then, of course, along for the right, there are other important markers of this dyslipidemic profile, like small dense LDL cholesterol and whatnot, and all these remnant particles. But it's interesting also that we see it sometimes in individuals who are not strictly speaking insulin resistant, and then, or not necessarily fitting the criteria for metabolic syndrome, but they usually have the leaky gut situation going on. So I think this is such an important realization, that a lot of patients have leaky gut and this chronic inflammation that happens in the liver. And then, of course, down the line, we'll make them insulin resistant, because it's, chronic immune system activation, and, everything is sort of progressing. Fascinating.
Absolutely. So there are absolutely, just as you're saying, there are different causes, and dysbiosis being one of them, right? Yeah, there are different, but not, and a lot of them, the dysbiosis, you now have to understand, well, what is that stemming from? What is creating and causing this imbalance in the gut microbiota? Yeah.
Hi, everyone. It's Dr. Regina here. Many of my colleagues and I are noticing patients coming to us with self-ordered blood tests. When this trend started to gain momentum, I thought it would benefit many patients. After all, who doesn't want more access to health testing? However, I see that self-ordered labs often lead to more confusion and frustration for our patients. Patients are coming in with a pile of labs, and sadly, they're not better off for it. This is why we at Holistic Heart Centers have launched Heartwell Toolkits, a curated collection of blood and genetic markers that one can get at home, focused on heart and brain health, gives you all the data you need to make informed and actionable health decisions. The toolkits can be ordered at our shop on holisticheartcenters.com. You can find the link in the show notes. Use the code TESTING10 to get 10% off and free shipping. So what would you say, Vivian, what are, I very often do a test, which is not technically even a test, it's a calculation. It's called, FIB4, which is a calculation of a couple of blood components that spits out this score that gives us an approximation to possibly is there liver fibrosis or not, right? So can you comment about the testing? Are you screening everyone? Are you screening just some specific people? Obviously, your practice most likely has a lot of patients presenting with this.
With fatty, yes. I feel like knowing the different possible pathophysiology of fatty liver, you almost want to screen everybody, right? Mm-hmm. It is metabolic predominantly, yes, but you could see a component of someone not having necessarily the full criteria of metabolic syndrome and has some degree of dysbiosis from whatever cause that you want to screen for. You see patients with issues with bile acids, right? Secondary bile acids being an issue, and you want to screen for them. We know the connection with uric acid, right? And in the uric acid metabolism that causes issues, you want to screen for them. And when you look at other causes of even fatty liver, what we call metabolic associated dysfunction, we are even seeing cases of patients who are just exposed to toxins, right?
Yeah, I was just about to mention that. Yeah.
So
POPs, right? Persistent organic pollutants are very common.
Organic pollutants, even preservative additives have been shown to change the microbiota as well. When you look at the stool studies, the microbiome of patients they've done mice studies where they've given them preservative additives in their food. So of course, this is a different kind of toxin coming from the food, and they're seeing how it impacts the microbiome and the changes and the different strains that they're seeing and the imbalance it causes. So there are many different causes. So really in today's world, if I could test everybody, I would.
You would, right?
Yeah, because almost everybody walking into my practice has fatty liver, and some of them you're like, where did you get this fatty liver from?
I know, right? So, and that's interesting because it's important for people to know that, at least in the old days, and, correct me if I'm wrong, but I seem to remember that in the old days, people were waiting for liver enzymes in biochemical profile to get elevated. And I don't think it's really justifiable anymore because, with the FIB4 score, which is just a computation that takes into account, a couple of commonly measured laboratory parameters. And, with ultrasound, I don't think people should really struggle and wait for their liver enzymes to go up. They should be.
No. And I think we're changing, that. We have to change the narrative there. And that has to start with primary care doctors, but empowering patients to also understand, empowering the individual to understand that you could have advanced liver disease and have a completely normal liver enzyme. Yep. You cannot rely on that blood work. And now with today's medicine, there's so many other tests that you can do to assess the health of your liver, which truly reflects the health of your microbiome as well. But I think one of the biggest thing patients want to know when they do an ultrasound and the radiologist tells them that you've got fatty liver, it usually will be seen when more than 5% of the liver has fat. There's 5% density of fat in there. So that's the initial sign, right? So it could be mild, moderate, or severe. And there are very good tests now that we can actually do to detect steatosis, right? So we
have... Such as what? Tell us about the good tests.
We have wonderful tests like Fibroscan testing and some of them are looking more at how CAP scores, which help us more with steatosis, and then also kilopascal, looking at how things transduce the elasticity of the liver.
So is that a sound wave being sent, like a vibration sound wave being sent into the liver, and then what reflected back and the measurement is taken?
Exactly. And so that kind of elastography helps us know how stiff is the liver, what's the liver stiffness, and that in its way tells us how much scarring and fibrosis is in the liver, right? And that fibrosis and scarring is in the liver. That measurement is important because that fibrosis, that scar tissue is actually replacing healthy tissue. Right. So you're losing your hepatocytes, those healthy tissues, those healthy cells that have a very, very important role in your entire body, as we know, the liver cells. And losing that means you're now losing the function of your liver.
Correct. And the liver it's a huge function, synthetic function, clearance function. And of course, we have to mention that patients who do have this metabolic associated liver disease or steatotic liver disease, unfortunately, are at increased risk of hepatocellular carcinoma, right? So there's also an association with that.
Absolutely. And think about the connection. The liver is the central organ that detoxifies, right? We go through stage 1, stage 2, phase 1, phase 2 detoxification and then elimination, right? And so when you're not only able to detoxify, as we know what happens when you're not able to release those hormones and detoxify from a female hormone standpoint. When you're not able to detoxify toxins that enter your body, you're going to increase your risk of all the inflammatory markers, the NF-kappa, toll-like receptors. Everything's going to be on fire.
C-reactive protein.
C-reactive protein.
Everything is there.
Going to increase your risk of cancer. So really that's how it happens, right? It's through that process. So getting a good ultrasound to assess how much fat, how severe is this? Also making sure that there's no other problem. It's not a gallbladder problem. There's no liver mass. There's no liver cancer. And then looking for potentially, if your liver enzymes are normal, we definitely would do a FIB-4 score, whether normal or not, because FIB-4 takes into account.
It's it's a calculation, takes them.
It's a calculation, kind of a standardized, the best that we have, not ideal, not perfect at all, but it at least tells us, what is the chance, if it's above a certain number, it tells us what's the chance that my patient has fibrosis in the liver. And now if this number is above the cutoff, then you want to do more advanced testing, like we talked about, liver elastography to actually detect what we call the Fibroscan test, to actually see what is the extent of fibrosis. And we grade this from level 0 to level 4 or 1 to 4. 4 F4 being fibrosis score of 4, meaning at this point you are cirrhotic, right? That is cirrhosis. 85 to 90% of your liver is scarred.
It's scarred. So what would you say as we are approaching, the closing time, your sort of top 3 pearls of wisdom for our listeners? Let's say they're listening to this and, gears are turning in their head. They're asking themselves, do I have fatty liver? Do I have leaky gut? Am I going to have all of these bad things that Dr. Vivian is talking about? So what are your top 3 pieces of advice that you can pass on, whether they have a test or not, what should they be doing?
I mean, so I guess, Dr. Druz, you have to go back to foundational. That's the most important thing.
I was hoping you'd say that. Go to foundational.
Keep things simple. All this testing is super important. But you as the patient, now that you have the information or you're trying to reverse disease, what is it that I can do to prevent this from getting to the stage of cirrhosis and increasing my risk for liver cancer? Number 1, remove the toxins. Alcohol, number 1, right? If you're drinking, this is just like putting salt on an open wound, gasoline to a flame. It's going to make the fatty liver worse.
And I have to tell you, as a cardiologist, there are so many times where patients have hypertension that seems to be resistant, or dyslipidemia that is resistant, or atrial fibrillation. And when you start digging and digging and digging, you actually end up finding that they are loading themselves up with toxins. And this whole thing that, if you drink 1 drink per day as a woman or 2 drinks per day as a man, that's okay. I'm here to tell you that this is a complete BS or bullshit, because individuals
are you allowed to swear on your show?
Yeah, I guess bullshit I can say. That's not like too explicit. It's just BS, right? But BS because people are sort of fooled or lulled into this sense of security. But the World Health Organization data is very clear. Alcohol is a toxin at any dose, right? So this is super important.
Super important. The second toxin that we don't talk about enough is high fructose corn syrup. That is the one that has been shown to be clearly associated with fatty liver. And that's why we are seeing so much fatty liver in our pediatric population. Children at the age of 14, 13, you are seeing, severe fatty liver. And it's because we are giving children Coca-Cola from McDonald's, the 32 ounce at age 2. So imagine
that's the uric acid connection, right?
Absolutely, the uric acid connection, absolutely there. And so we've been giving them this since age 2, and they've been drinking it still there in their, 10 years later in their teens, their liver is fat. So those are 2 easy things that I think it's really important to stop right away.
And and may I add into this ultra processed foods, right? Because we know how detrimental ultra processed foods are. So
simple things that you can remove.
Exactly.
We don't always have to add. Sometimes we have to start by removing. So alcohol, high fructose corn syrup, sodas, ultra processed food. That's anything that is fast food. That is a lot of things that you cannot pluck from the earth and grow and cook, and things that are made in a factory, heavily processed. Additives are added so the shelf life can be 100 years old when you go back and get it. That all has to be removed. That's the number one place to start. The second thing that I think that we don't put enough emphasis on is exercise. One of the biggest things that can reverse, of course, as you know, cardiovascular disease and metabolic dysfunction is just an arm of that, really, in fatty liver, is that there's a strong impact and there's a huge benefit of moderate activity, even if it's just walking 30 to 45 minutes every day.
Exercise snacks, right? Remember the exercise snacks?
And adding variety to this exercise, combining, we know the best thing is that combination, right? Continuous moderate activity, a little bit of HIIT training, high intensive impact training, and then a little bit of and that weight bearing exercise, the weightlifting and muscle building. That combination is ideal when it comes to really making sure that insulin is used by the best in the right way.
And I think this is super important because there is a lot of emphasis right now on resistance training, improvement in muscle mass, which of course are all very important. But sometimes what I see patients doing is that they sacrifice their zone 2 aerobic training to do that. And this is wrong, because that's not going to allow them to maintain their VO2 max, which is very important, for cardiac performance, anti-aging perspective, and certainly not going to allow them to be metabolically flexible, even if they do build more muscle mass. So this has been absolutely phenomenal, fascinating. If, feel free to share with our audience any links, to your practice, to any products or courses so that they can learn more about microbiome, leaky gut, your signature program, fatty liver. I'm still going to call it fatty liver. So, it's just a colloquial term, but, MASLD, is a more appropriate term. And thank you so much, Vivian, for being a part of this show.
Thank you so much for having me on, Dr. Druz. I felt like we could talk forever and ever, but we got to end somewhere.
Totally. Hi to all professionals listening to us today. If you're thinking of launching a cardiometabolic or integrative cardiology program in your practice, we can help. At the Holistic Card Centers, we help docs in practice to expand into hybrid or concierge services. Head out to the show notes and click on the application link. Your intro call is entirely free. Ready to schedule a practice review? Use code DOC10 for 10% off our Practice Power Hour 16 minutes coaching session. The link is in the show notes. Thank you for tuning in to Own Your Heart Health with Dr. Regina Druz. This podcast is powered by Holistic Heart Centers. If you enjoyed the show, please rate and review us on your favorite podcast platform. To learn more about our services, visit holisticheartcenters.com and subscribe to our YouTube channel. The link is in the show notes. See you next week.